Hi, it's Stacy Kiltz. In this voiceover, we're going to go over labor interventions and birth complications. I'm not going to be going into too much of a details on the voiceover. We'll be dealing with the topics more in class. This page is just a brief outline of the topics I'll be covering in this voiceover. So there are occasions when labor doesn't start spontaneously and a woman needs to be induced. There's also some medical indications that would result in a client needing to be induced before labor began. The Bishop score is actually used to see how favorable the cervix is, and you can see the scoring system there done by vaginal exam by the practitioner. The score of 8 is or higher is favorable for a successful induction. Leopold's maneuvers are maneuvers that are done to determine the fetal position in the maternal abdomen. The first maneuver determines what part of the fetus is located in the fundus or the top of the uterus, whether it's the buttocks or the head. The second maneuver determines the location of the fetal back, and you're holding one hand steady on one side, palpating with the other. Knobby little bumps usually indicate the arms and legs, whereas a smooth, firm surface indicates the fetal back. The third maneuver helps to determine the presenting part, and then the fourth maneuver tells you how the head, if they're head down, how that head is sitting in the pelvis if it's in a favorable position. A fair amount of inductions that are done before 39 weeks of gestation will need some form of cervical ripening, and that can be done with a number of ways. There's balloon catheters, there's laminarias, which are seaweed sticks that go in, and as they absorb the vaginal fluid, they expand and push open the cervix a little bit and also soften it up. And then there's medications, mostly prostaglandins, that can help ripen the cervix. If there is some dilation already, usually about between 3 and 5 centimeters, the OB provider can do what's called membrane sweeping. Basically, they're taking their fingers and rubbing them along the amniotic sac during that vaginal exam. If they're in the hospital already and client is dilated, the OB providers can also break the bag of waters, and that's called an amniotomy. They basically use a plastic device with a little hook on the end and go in and tear the bag, and that will often trigger contractions in the client. The most common medication used in induction and augmentation is oxytocin. Now, your body does make its own endogenous oxytocin, and that will help with stimulating uterine contractions. It'll also be involved later on in the breast milk production process. But prior to delivery, you can give synthetic oxytocin if you're trying to get the labor started and get a contraction pattern going that will dilate the cervix. It is a high alert medication. Oxytocin needs to always be on an IV infusion pump. It should never be free flowing. It should be connected to a main IV line down at the port closest to the patient. It should not be the main line. You should be able to quickly disconnect it from that port. While oxytocin is infusing, you are carefully monitoring maternal vitals and fetal heart rate and contraction patterns. The fetal heart rate, maternal vitals response, or a contraction pattern that's too intense or causes dips in the fetal heart rate would necessitate stopping the infusion. Facilities would have a policy on where to start, how much to go up, how often, when to stop the infusion, when you could restart it. As students, you will not be dealing with oxytocin infusions. You might be asked to calculate one, but you would never be administering it yourself. You also need to monitor I&O carefully with oxytocin because it can cause fluid retention. So oxytocin can also be used for augmentation of labor. This is when a woman's come in spontaneous labor. She's been there for a while, but the contraction pattern isn't kicking into something that's going to dilate the cervix. You could hang the oxytocin and it'll help strengthen and regulate those contractions and hopefully shorten the length of labor. Again, you have to watch for the tachysystole more than 5 contractions in 10 minutes, and you have to watch for any abnormal fetal heart rate patterns. As the nurse, your responsibility is going to be to make sure that there's all the consents in the chart for delivery before you start any sort of procedure like induction, and that the client's in agreement with the plan. You want to review the prenatal record and get all the pertinent information out of there, especially the patient's blood type. Most clients, while undergoing labor induction or augmentation, are on continuous external fetal monitoring, and that should be evaluated and documented every 15 minutes once they get into that active phase of labor, and then every 5 minutes when they're pushing. You want to watch the fetal heart rate and how it responds to the contractions. You want to see a progression of about 1 centimeter in an hour with these clients. You want to make sure the amniotic fluid stays clear, they're not bleeding too much. Assess mom's level of comfort. Oxytocin causes contractions. Contractions cause pain. So this mom's going to need pain management, both pharmacologic and non-pharmacologic. Monitor her vital signs, and then again monitor for the fluid overload with the oxytocin. We only touched on fetal heart rate monitoring a little bit, and we'll be doing more in class, but there are times when that strip isn't looking the greatest, and it'll be called category 2, category 3. Basically, you don't have the good variability, you've got decelerations occurring. You have to use what are called intrauterine resuscitation measures, and these will help promote fetal oxygenation. Best thing to do whenever you start seeing those decelerations occur is to flip the mom onto her side. If she's on the left, flip her to the right. On the right, flip her to the left. Sometimes that's all you need to do, and you get the improvement in the fetal heart rate. Other times you need to give an IV fluid bolus, typically 500 milliliters of lactated ringers. If they're having an induction and they have any sort of the prostaglandin inserts in their vagina, they need to be removed. The oxytocin needs to be turned off. They stop pushing for a while to rest and let the fetal heart rate recover. And we also still do administer oxygen at 10 liters via non-rebreather face mask so that we can increase the fetal oxygen concentration. So these are those basic intrauterine resuscitation measures that there's usually standing protocols for, and the nurse just applies them in response to that fetal heart rate strip. Now, external cephalic version is an intervention you might see if a mom's about 37 weeks pregnant or so and the baby is breech. The provider can bring the mother in, use medicines to relax the abdomen, and then with their hands try to maneuver the fetus into a head down position. This needs to be done in a hospital setting and one that's ready for an emergent delivery in case during the process there's fetal distress. If the version is successful, the mom will be monitored for a little while to make sure there's no contractions developing, and then she'll be able to go home and hopefully be back in spontaneous labor with a baby that's head down. If the baby reverts to breech, they'll have to do a C-section. Sometimes during the delivery process, a little assistance is needed to help deliver the baby vaginally. And these are called operative vaginal deliveries. And this is when either forceps or vacuum extraction is used. Forceps are spoon-like, and they go in to help pull down the baby's head. They are rarely used now. There's very few providers that still know how to use this technique and do it properly and do it often enough to do it well. Most OB providers are now using the vacuum. Head has to be low. You can only attempt it 3 times. If the 3 vacuum attempts are not successful, the client will need a C-section to deliver the baby. These procedures are uncomfortable at times, depending on what kind of pain medication the client has been using during labor. They can lead to vaginal and cervical trauma. After delivery, you want to carefully examine the newborn closely for head trauma and or marks or bruising from either of the devices used. An obstetrical emergency that might occur during delivery is a shoulder dystocia. This is when mom's got to the pushing stage and that baby is there on the perineum. With the contraction, the head will come out a little bit, but then pull back into the vagina after the contraction's over. This is known as the turtle sign. This condition is also characterized by a delay in delivering the shoulders after the head is delivered. Basically, the shoulders can't get out. The problem with this is that the baby can asphyxiate if it takes too long to get the baby out of this position. Once it's recognized, they have to call for immediate help. You instruct the mom not to push. The OB provider will ask you as the nurse to participate in positioning the patient. One nurse on either side will pull the patient's leg straight back, and one nurse will also apply suprapubic pressure, not fundal pressure up top of the uterus, but suprapubic right above that bone to try to push that shoulder down a little bit, open up that outlet, pelvic outlet, so that the shoulders can be delivered. If that maneuver doesn't work, the OB provider can try to twist the baby so that the shoulder will fall, one of the shoulders will fall under the arch. And this is going to happen in a very short period of time. They'll try these maneuvers, and if they're not successful, you have to get them to the OR as soon as possible to deliver this baby. Fetal brain damage can occur if the baby is not delivered within 6 minutes of the onset of the dystocia. Another obstetrical emergency is a prolapse cord. Usually the mom will say she felt a gush and something feels like it's in her vagina, and it's found on a vaginal exam. The person who finds it stays with it. You need to get the pressure off the umbilical cord, so the gloved hand that went in to examine the vagina will feel for the cord and the cord pulsation and try to keep the presenting part off the cord, and then get mom to shift into a knee chest position or Trendelenburg, and then they will be rushed as a unit to the operating room for delivery by cesarean section. Another obstetrical complication, while rare, can be very deadly, and that's called Anaphylactoid syndrome of pregnancy. It used to be called amniotic fluid embolism, and it can happen during labor, delivery, or the immediate postpartum period. All of a sudden, mom has symptoms of respiratory distress, can't breathe, blood pressure's dropping, she gets cyanotic, and this can lead to pulmonary edema, DIC, and cardiovascular collapse. They think it has something to do with amniotic fluid entering the circulation in the mother and triggering an allergic-like reaction. This syndrome needs to be rapidly recognized, and interventions need to start immediately to prevent maternal fetal morbidity and mortality. Now, we have talked about DIC, or disseminated intravascular coagulation, a little bit in previous lecture. This is usually the result of an obstetrical complication that starts the clotting cascade, be it a bleed or a trauma, uses up the clotting factors, and then mom starts to bleed from other places. If this situation develops, you need to notify the blood bank, initiate massive transfusion protocols. It's a code situation, and you need all hands on deck, and the client will need an intensive care bed and aggressive management to survive. Your books cover Everything I've discussed in this voiceover in much more depth. I've tried to give you the highlights in this voiceover. If you have any questions, please feel free to email me.